Okay, we are now live. It's 12 o'clock on Thursday, September 4th. Hope everybody's doing well. Really nice weather. You come to work, it's in the 50s or low 60s. I got a haircut last night. Look at that. Wow. So got my beard. It was trimmed a bit, but got a medium haircut. And Angel, who cuts my hair for the last probably 40 years, did it in the driveway of my house, so I wouldn't mess up the house. But did it in the driveway. Had a few deer watching. Didn't bother us. So anyway, whatever. Every 3 months, get a haircut. Let's see. Other than that, we are working on some new apps and updating apps for the App Store, and you'll see hopefully soon. Apple is giving us a hard time on our newest app. I spoke to the person who was evaluating the app and started telling me that he knew better, and I usually don't like to pull rank or drop names or give the once over, but I tried to be patient, and then I just told the person what we do, what we've done, and that person has never written an article or made an app probably or done anything and knows nothing about medicine. So how to tell me what's interactive or how we should do things, I thought probably was inappropriate. So we'll see. Apple is Apple. Apple had a good week. The Google #1 lawsuit. They don't have to give up their operating system, and it works out. It's complicated, but that actually Apple benefits. So life is good, and I think next week Apple has their new announcement, their new iPhone. Probably iPhone 17 is coming. I just bought 16 a few months back. My phone was dying, but 17 and new watches and God knows what are coming next week. I think the 9th is the meeting, so you might look for that. Today's talk is CT of lymphoma, and what can I say? Lymphoma is one of the common things we all evaluate, either staging lymphoma, patient with fever, we suggest lymphoma, or following up lymphoma. Lymphoma, as we know, involves many organs. It could just be adenopathy in the chest, mediastinum, interior, middle, or posterior mediastinum, or all of them. We also, in the abdomen, you think about adenopathy, bulky adenopathy often. But you have to go organ by organ. Diffuse gastric wall thickening. When it's bulky, think lymphoma, but more and more it looks like adenocarcinoma these days because we pick it up earlier. So in the old days we would say over 5 cm means lymphoma, but I rarely see a tumor in the stomach except for a GIST tumor, which is a different appearance, being 5 centimeters or greater. We talk about the liver, lymphoma in the liver and spleen, best seen on venous phase imaging. And in fact, on arterial phase imaging, particularly in the liver, you may just not appreciate the lesions that are present. We wrote an article this past year on lymphoma of the adrenal glands. The adrenal can be involved in systemic disease, but also primary adrenal lymphoma, where only the adrenals, large adrenals, 10 centimeter range, adrenal shape, bilateral typically. We talk about the kidney. I gave conference yesterday and showed a bunch of renal lymphomas to, I think, Linda Chu, whether they're solid masses looking like a renal cell or even an abscess, multiple masses, unilateral or bilateral masses, infiltration of the peri or pararenal space, diffuse infiltration tracking into the mesentery, extension upward toward the adrenal or toward the aorta, many appearances of renal lymphoma. We talk about appearances with bowel, right? Focal masses, polypoid, which can intercept. Multiple interceptions, you got to think about lymphoma, but also melanoma. We talk about large, bulky, and ulcerating masses, long segment infiltrating masses. We talk about lymphoma involving the colon as diffuse infiltration. We talk about lymphoma in bone, right? You talk about infiltration and destructive lesions, particularly in the pelvis, iliac bone, or sacrum, can be multifocal as well. Scanning protocols, I like IV contrast. Water is a positive agent. though some people say maybe give positive contrast, might be easier to pick up small bowel lesions with lymphoma when they're smaller. So small bowel tumors. Either way, I think with lymphoma you typically do single phase imaging. Again, venous phase is ideal. In the chest, we talk about adenopathy, I mentioned, but you can have lung nodules, either solitary or multiple. You can see infiltration from the hilum into the lungs, lymphatic spread. You can see cardiac involvement involving the pericardium or individual chambers. Those are all possibilities. Lymphoma can look like many things. When you look at cases, when I do quizzes and you show cases or you're doing real patients, lymphoma and things like melanoma can look very similar because melanoma has an infinite number of appearances. So melanoma can involve multiple organs, like lymphoma, can involve single organs, can be solitary or multiple lesions in the liver, the spleen, the kidneys, pararenal space, lymphoma, and melanoma is what you think about. Melanoma can go to cardiac chambers. Melanoma can give big nodes in the axillary regions, periaortic regions, as well as in the abdomen, whether it's the upper abdomen or it's in the pelvis or inguinal regions. Melanoma also can involve muscle, very much like lymphoma. So both of those have a lot of varying appearances. In terms of lymphoma and the CNS, brain and spinal involvement is not uncommon, and that's best going to be visualized with MR. PET can be very helpful in terms of staging, particularly for looking at occult sites. There are new chemotherapies for lymphoma. New ones are being developed all of the time, combination chemotherapy. And patients who would have done poorly just a couple years ago now can be cured. Also, lymphoma with immunotherapy is being investigated at multiple sites and multiple different protocols. So I think we are striving and doing a good job working on lymphoma, decreasing morbidity and mortality. In terms of the adrenal glands, one thing I always mention is we don't biopsy the adrenal glands unless it's like metastatic disease and the patient's not a surgical candidate and we're just staging. But the other time is if you think it's lymphoma. So it's important to be able to recognize lymphoma. I mentioned bilateral, typically there can be unilateral. Big adrenal shaped masses are classic. So you would hate to have a patient go to surgery for lymphoma and think it's an ACC when it's really primary lymphoma. So bilateral large masses, even if there's no other disease present, you got to be thinking of lymphoma, and in those cases we will biopsy. So that, breaks the rule, but is the way and the ideal way to manage patients. So with that, hopefully I've given you a little taste of lymphoma. I am working on a couple lectures which will be helpful. There's a lot of cases in the teaching file you can look up. And with that, I'll wish everybody a great day. Let me look at my viewing community here. Let's see if I can see anything. There's a whole bunch of people on now, but I'm not sure how I tell who's there. It used to be so much easier. Facebook has a way of constantly changing things that make life more difficult. I can see the current viewers, but I don't know who you are. So I apologize that I can't call on you or give you a shout out. And I've just tried 2 different ways and neither of them seem to work. So with that, I'll wish everybody a great day and see you soon.